Good morning, everybody. Good to go. Good morning. Welcome to the Enhancing Clinical Practice and Outcomes stream at the SNOMED CT Expo 2024, first of the 2 days. My name is Rory Davidson. I'm the Chief Digital Information Officer at SNOMED International, and I'll be moderating today's session. All questions will be answered at the conclusion of the presentation. Online attendees, please use the Q&A button to type your questions to the presenter. On-site attendees, please use the microphone that will be provided. Please raise your hands and we'll give you a microphone. With that, I'm very pleased to introduce Anthony Shek from Guy's and St Thomas's Hospital and King's College Hospital in London, who will be presenting Realizing AI's Transformative Impact in Healthcare, Real-World Benefits for SNOMED CT from London Hospitals. Anthony, over to you.
안녕하세요. Hi guys, I've been practicing that all morning, but what a fantastic keynote speech that we saw, and I feel like he covered a lot that we are trying to do over here in London. But yeah, first of all, I would just like to say there's been a huge amount of collaborative effort, and I'd just like to thank the entire team. That's some of them are in this room, but all the patients and doctors, and I guess the rest of the engineering team that I've left back at home across London in the variety of hospitals. And that none of this work would have been possible without them. So, and all the collaboration and communication and administrative staff to facilitate this kind of work. And so just a little bit of a background about myself. I'm a lead natural language processing engineer at Guy's and St Thomas Hospital. We operate collaboratively across universities for research and a number of hospitals across South London. And so today I'll be talking to you a little bit about some of the use cases and applications of artificial intelligence and how I'll give you a bit of a taste of how we've used that in the hospital. And so first of all, I'll talk a little bit about the landscape. Artificial intelligence, what's the sort of hype. I'll talk a little bit about the current medical landscape in the hospitals as well. I'll talk a little bit about why investing into the infrastructure of AI is so fundamentally important and various considerations of using this as well. I'll then move on to some selected use cases and where are we trying to go. And so I guess to start off, the EHR is a lot of the clinically valuable information that clinicians would like to use is directly stored within the free text. It's predominantly used for direct care purposes. And so you can, the easiest way for a clinician to enter information is generally, or the most natural way is to enter things through free and natural language text. But ideally, we want to structure it if we want to do for anything for any form of analysis, right? But only a small proportion of that information across the record is structured. But within the unstructured text or the clinical narratives resides the majority of clinically valuable information. So these can be certain informations about clinical biomarkers, genetic tests, various disorders and symptoms, lifestyle choices, and medications and drugs. And that's often trapped or not readily, easily used for analysis. And so just to quickly remind everyone, what I mean by unstructured is that there's no data standardization requirements. So it's not like a date where you can have month, day, year, or day, month, year, where there's a predefined format to enter the data. And so if you can structure all that data, there's a variety of use cases or benefits that can emerge from it. It can be much easier to analyze and create reports. And from that, you can do audits, improving the quality of care, various clinical support systems, improving clinical patient safety, various population health management, and research. But ultimately, this enables, by structuring data, it enables organizations to readily search their own data and empowering to make their own data-driven decisions. And so these are all downstream use cases of organizing your data. And of course, it's not just about structuring data, it's about structuring it into a format that's interoperable. into various standards like SNOMED CT, ICD-10, RX norm. That allows different healthcare systems, players to be interoperable within each other, to be able to share and communicate efficiently. And so just having a look at this emergence of what we call artificial intelligence, or more recently, what's been capturing the imagination of everyone has been this idea of natural language processing, or but specifically this generative AI. And so generative AI is just a type of artificial intelligence that can look to produce new data or images or music or any sort of data modality, really, that resembles the data that it was trained on. And so this wave of artificial intelligence, which was sort of spurred on to the public by the release of ChatGPT, has really captured the imagination of everyone, right? Everyone has been able to see the potential, and everyone now is asking, how do we do AI? And I guess the reason for that is because these large language models do exactly what I do on a day-to-day basis, right? And that's, I can summarize, I simplify, I organize, analyze, compare. And you can see a little bit of that you can see glimpses of that in a lot of these models of text. And although now that's captured the imagination of a variety of stakeholders, everyone is like, how do we do AI? We want to, how do we use AI to resolve our finances? How do we use AI to, automate our HR department? But I guess a very important factor first is that there is underlying infrastructure that needs to be built first before any form of AI can be built, whether it be natural language processing, computer vision, or any form of machine learning. And that involves investing into the underlying infrastructure. And we saw that today from the speech from Kakao Health, and how they've made it interoperable, made their data standards, and have a federated learning platform on top that sits on top and across hospitals, how to seamlessly share and train models across various hospitals and organizations safely and securely. And so by investing into the infrastructure, it allows you to organize your data, and you can silo it. And from that, you can then start applying various artificial intelligence. So this is a very oversimplification of this potential foundations for an AI factory, which is from which you can then start producing each of your various machine learning or AI NLP models. And so I guess an analogy to this is looking at the success story of the COVID-19 vaccine in the UK. It didn't just happen overnight, where we were the first to roll out and for general purpose use the vaccine to millions of people. But there was years and years of investment into the life science industry that made it very much possible. And so the same thing needs to be done with artificial intelligence. And I guess a key part is that, everyone looks at jumping at these AI models, but they change weekly, let alone monthly, daily. But the fundamental behind it, or key component, is the data. And to structure and organizing it, that will not change. And so a very key component of, as I said, of, structuring the unstructured is, well, first of all, how do we take out valuable clinically valuable information from the free text? So we've got this tool called MedCat, where you can enter any form of free text and it extracts SNOMED CT codes. Not only does it extract the SNOMED CT code, but it can understand the context in which it's represented in as well. So irrespective of spelling mistakes or acronyms or synonyms, this tool will be able to understand what part of it relates to which concept accurately, and which part is not relevant at all. A key part of this is not just the recognition of the term or entities, it is the understanding of the context. And so where it says no night sweats, it needs to understand that, yes, it is night sweats. However, there is a negation to it as well, so it shouldn't be extracted. Similarly, there's other information, metadata about it to say whether it belongs to a patient or not, whether it's historical information or whether they're at risk of something. And so when you can have an AI that can read and label free text automatically in an accurate manner. So on the left-hand side here is, I guess, in each gray box is a label, an identification of which bits of word matches to which SNOMED CT code. And so we extract the things that are relevant depending on the use case, things that belong to the patient, that are not negated, and are recent or maybe a past medical history. And we map it and we can structure it. So we're taking this nuance of acronyms, synonyms, spelling mistakes, and we're aggregating terms that mean the same thing. So in this case, we can map to either SNOMED CT, and because of the inbuilt mapping in SNOMED, we can also map to other ontologies as well, like ICD-10. And so looking at the first column that says epilepsy, you're not just extracting the term epilepsy from this text. You're understanding whether it's epilepsy clinic. That's not what you want to be extracting, because you can be attending an epilepsy clinic without having epilepsy. But the terms JME, juvenile myoclonic epilepsy, right? It's a child term of epilepsy in the SNOMED hierarchy. That's what you want to be extracting. And can you use the inbuilt human curated knowledge that's found within SNOMED CT to be able to aggregate and group together a variety of codes? And the answer is yes, yes you can. So over here is just a count of all the concepts that are mentioned, where each row represents a document. And this this tool, I guess, operates and can read documents at a speed of over 50,000 documents an hour. So it's much faster than any human can possibly read and structure and organize text. It's also, I guess, one of the benefits of AI is that it can be consistent and standardized. And so I guess when you can structure some of the unstructured, here's just a little bit of an outline of the infrastructure that we've got going on within a single hospital, where we can take data from a variety of legacy data sources, from the current EHR database, and we can merge it together. And if it's structured, we've got a pipeline to add our structured data in what we call an OMOP plus model. Whereas our unstructured data, or the narrative reports, particularly textual, we've got this whole pipeline of an NLP service that we can process, curate, moderate, check. And once we've structured the data, we also feed that into our OMOP plus common data model. So by combining all that data, we have a centralized data set within an organization. That on top, similarly to what we heard from Kakao Health today, you can then federate querying or apply federated learning across each hospital. Oh. So a key part of these natural language processing models is making sure it works properly, right? Yes, it may be consistent, but it can also be consistently wrong, right? So how do we process this in a way, and how do we make sure that our models are working? Well, we have this validation cycle. So first we retrieve a sample of documents, and we have, from a proportion of it, we have expert doctors or domain-specific doctors with a specific domain expertise validating their area of choice. Because we've got a model that we can look to filter for concepts or certain areas of SNOMED CT, we have the stroke clinicians annotating stroke terms. We have the cardiac clinicians annotating cardiac terms. We have the epileptologist labeling epilepsy terms as well. And so essentially what they're doing is producing an annotated data set, and this is what we call validation phase 1, where we are looking to validate whether the model is an accurate or can give rough estimates that if it's good enough. So we're producing a gold standard. So are these doctors extracting the same thing, these expert doctors in their own clinical domain, are they extracting the same thing as the model? We can then run the model across the entire data set and extract a variety of SNOMED terms. We can then group and map, as I said, to either SNOMED terms, map to ICD-10, group by patient, group by medical visit or episode or visit. And we can, basically it depends on your particular use case. And so at this stage, at the very end, we need to also validate that, because this is a whole, I guess, a data science pipeline, and mistakes can happen not just in the NLP part, but it can happen at any part of this chain. And so I often recommend that the less steps you do, the less chance you are likely of introducing a mistake. And so, for example, you might have the perfect NLP tool that can read, but if you've only extracted documents from 2020 till now, any data, if you're doing a study from 2005, will be missed, right? So not a mistake from the model, but a mistake from the data science pipeline. So here's an example of a bit of a workflow that we have going on in the hospital, where we take in requests from a variety of doctors as well. So what we try to do is align incentives. So I mentioned earlier about having the stroke doctors training stroke terms, the cardiologists training cardiac terms. And so, you know, we don't necessarily have to pay them, right? I mean, ideally you should, right? Because they're doing work. But what we realize is that they are doing this work anyway in the form of audits. They are actively reviewing and curating the data and evaluating their systems and their levels of care. But what we learn is, well, rather than instead of using and doing this audit information in an Excel file and then disregarding it afterwards, what we can do is introduce a labeling process which makes their audit process easier. But we are reutilizing that annotated data to train models and to automate it in the future. And so in the future, rather than having them to do another audit of the same pathway and start again, they can just be validating a small proportion of that model. So over time, you're doing less and less work. Because I guess the last thing we want to do is adding more work to our clinicians and doctors. And so, yeah, that's a part of the MedCap process or the NLP process, where we have a setup, we have an annotation, we have a QC step, and it's this key point here that I'm trying to emphasize is that it is iterative and it's continuous and it's ongoing. And so, okay, once we have annotated and we've got our data and we're happy with the performance of our NLP model, well, what does that look like, right? And how does that look like in practice? So, you know, from stage 1, we can choose different aspects of the HR, which in phase 2, okay, we've got it all centralized. We've got all our documents that we've stripped of all the structure, whether it's PDFs, Word documents, TXT files. We run our NLP algorithms on top. And then from number 3, we can readily put on dashboards, right? It's all structured. You can enter any SNOMED CT code, combinations, and you can search across patients and combinations of patients live. So we have now surfaced all that trapped and unlocked that kind of data. And of course, you know, as I said, dashboards, you can put all sorts of pre-made visualizations as well. So, and yeah, of course, a key component of this behind this has been SNOMED CT. So I'm just going to run through a selective number of use cases. I'm not sure how I'm doing the time, but I might whiz through some of these. And so, you know, we spoke about annotating with SNOMED and mapping to ICD-10. Well, of course, well, you know, can't we automate clinical coding? And to a degree we can. We're not saying that we can fully automate it, but there's a selection of the codes that are very, I guess, relatively simple to validate and code and, you know, accurately extract. And so what we've found is that, you know, there is a huge amount of benefit or current coding inaccuracies that are found within the record. So these clinical coders often come from non-medical backgrounds, and by using this AI that, you know, can read throughout the night and day, we found direct financial benefits for outpatient procedure codings, looking at particularly comorbidities of 5.5 million and of additional income realized in this year 2003. Same applications happen for the inpatient coding as well, and we're just looking at the degree of mismatch or margins of error. That's a bit more administrative use cases, but there's also clinical benefit as well, where there are potential risks to patients on certain medications as well. So if we can structure and have an AI read all documents and records, how do we make sure that certain side effects for certain patients are flagged immediately when they indicate some immediate adverse risks? And I guess lastly, lifestyle, work. How do we identify veterans and armed forces individuals that can be you know, because in the UK, we are very proud of the armed forces group and they're entitled to an additional level of service. But many of them don't realize this and aren't aware. So how do we allow this support system to be able to identify who's a veteran and contact them? Well, we can structure the data, we can let them know. So I'm not going to talk too much about this, but my colleague will emphasize a little bit about this, but this is a tool called MyAid, and it's a medical information AI extractor. So we're talking about all this NLP tools, but this is about how it integrates within a platform called Epic. But ultimately, this can be within any EHR as well. So free text and directly, almost cite as you write, and a SNOMED code will appear. So take the administrative burden away from the doctors. Don't have them memorize all the SNOMED CT codes. And so just to wrap up some future directions of where we're going, which may be quite exciting. In the same way how a lot of this generative AI can predict and generate sentences by learning through historical data, we can structure and extract data and form a timeline, a sentence, a story of one's health. And if we can tell the story of one's health, we can continue on that story as well. In the same way how ChatGPT can continue a story of how SNOMED CT's Expo went fantastically, it can tell the same story about how this patient who visited the hospital, what their likely outcomes will be. And it does that through learning from all the patients who have been through the system. So can we learn from patients that have used the system and apply that to new patients coming in? You can also edit that story and pretend what happens if they take this path or that path. Well, in the medical term, if they take drug X versus drug Y, if you make this decision or that decision. Another aspect is a project called RAVE, a referral automated vetting engine, another NLP tool that isn't primarily based on information extraction, but what it does is ingests a lot of patient referrals. Doctors, often refer patients and take a long time to read through all their documentation and understand the priority or the eligibility or inclusion, whether this patient should be admitted for this clinic or not. And so in a very similar RAG pipeline, you can read the documents, read all the national guidelines, understand the inclusion, exclusion criteria set by that specific clinic. We can process and triage the document and send it to a report to the overseeing clinician to see if it should be reviewed or not. And our last one is our push towards multimodal large language models. We realize in the same way how we can encode or understand text, you can do the same thing with other modalities. Healthcare is not just text, it's images, it's tests, it's histopathology, it's genomics. And can you combine these to a degree and potentially chain it as well to a way that you can interact with, in this case, speech? So is there pleural effusion present in this image? And it can say yes. You can also structure the output into a variety of formats to then use for downstream purposes. And so on that note, thank you very much for listening. And yeah, 감사합니다.
Thank you very much, Anthony. Another fascinating presentation. We'll now take some questions. As a reminder, if you're in the room, please raise your hand and we'll come and give you a microphone. And if you're online, please type in your question in the Q&A in the Zoom app. So questions in the room. I will kick off a question then. One of the biggest challenges with AI is obviously privacy. How are you tackling that within the environments that you're working in and that we can show in your presentation?
Yeah. So I guess there's two aspects of that, right? There is, because we're dealing with free text, there are, and this free text is often reports about the direct patient or their communications. There's a lot of sensitive information about the names of the patient, where they live, where they work. And ideally, we don't need that, right? We don't actually care about who the individual is. And so that information can be redacted. And so when I say not just redacted, I don't mean attaching and removing and adding asterisks and covering it up, which in some ways it can be useful, right? That's plain redaction. What we do is a form of replacement, where we replace names with a placeholder that says name or sister's name or father's name. And so the reason that is valuable, it protects the safety and the privacy of the individual, but also it helps a lot of our large language models or language models perform even better on the text. So I would say there's even, there's not just, an excuse that, this is an extra step, but actually you get better performance because a lot of diseases, a lot of names can be confused with this sensitive data. So if I took an example of, you know, DM, right? That could be an initial, right, of a person or an individual. However, that could also be diabetes mellitus. And so a lot of these models that can understand whether something means a name or a disease, it works quite well, and you just replace it. And yeah, certainly a lesson that there is certainly no excuse. And if anything, there's an incentive to get even better performance from your model, because as I said before, a lot of disease names are named after people and individuals as well. So to avoid that confusion, always anonymize it first, or redact the identifier is what I should say first.
Any questions from the floor?
Thank you for your presentation. This is Veronica from Hong Kong. Your presentation is amazing and eye-opening. I want to ask that in your presentation, you used the MACCAT for the inpatient or outpatient coding with the SNOMED Flow AI. So is it already adopting in the hospital, and will there be any plan to implement in the whole NHS hospitals? Thank you.
Yeah, no, thank you very much. So, yeah, so this was, I guess, a bit of a test where we did a health economic study to understand proof of concept, where we had clinical coders evaluate and double check the performance of this model, and retrospectively go back and made us realize, hey, we can actually find some additional revenue that the hospital can grab. Do we want to roll this out to the entire NHS? Yeah, absolutely. You know, but you know, as we all know, technology evolves so fast and so rapidly. I think what we're trying to emphasize and kind of say first is to, you know, this benefit will come, but we need to first invest a lot more into the infrastructure behind AI across hospitals, and, you know, be able to share these models, you know. So it's not just, I guess, the infrastructure, but it's also the governance. I know the NHS sounds like a single organization, but actually it consists of multiple organizations where each hospital is an individual institution. And so sharing can be quite challenging. But what we're trying to emphasize is that there is lots of benefits to sharing, right? If you train a model on one hospital in the UK, the language and the style of writing is very similar, right? Not identical, but very similar. And so if you share, that it means that they don't have to do as much training, and maybe they can just be validating, right? So you share from one hospital to another, and they are already skipping a lot of work. So collaboratively and approaching this work together, we can all benefit from better AI models and systems.
Thank you very much, Anthony. We've come to the end of the session. Fascinating as always. Please thank Anthony.
Thank you very much.
So with that, we conclude this particular session. Online delegates, you can stay here for the next presentation. And those who are in the room, you can stay in the room for the next presentations. We've got a couple of minutes. Run. No.